One, and we are live. Good evening, everyone. We welcome you all to Ortho TV Online in association with Oref. To introduce today's topic and speaker, I hand over to the chairman. Over to you, Dr. John, sir.
Okay. So let me just share my screen. Is that okay?
Yes,
Okay.
sir. Yes, sir.
So welcome everybody to today we continue our series of talks on pelvic and acetabular fractures. And today I'm going to be covering a little bit about the pathophysiology of major trauma, and Professor Kong will be talking about the acute management of pelvic trauma. Without much ado, I'll get started. I think when we think of major orthopedic trauma, there's a series of fractures that we think of, and hopefully by the end of this talk, we understand the pathophysiology of major trauma and the patient's underlying susceptibility for second-hit insults. We should be able to distinguish stable, borderline, and at-risk patients. We need to set priorities for the management of injury and consider the suitability of damage control surgery. So I think fractures which cause major blood loss or significant pathophysiological changes among the orthopedic injuries include the long bone fractures, especially femoral fractures, pelvic injuries, especially unstable injuries, and of course, unstable spine injuries. And you can have different clinical scenarios. And this is a classical sort of a problem which a lot of us have faced during our life, where you have a young patient with a motorcycle accident with apparently no other injuries, seems to be okay. You take him to the OR and you nail his femur, and during surgery or a day later or 2 days later, suddenly he starts having problems with his breathing, his oxygen goes down, and you have to shift him to ICU and sometimes even intubate them and treat them for the problem. Now, this was could be for various reasons, and if you look at it, the commonly thought problem used to be fat embolism. The patient could have had an occult chest injury which has got exacerbated, or it could be the timing of surgery. People would say that, oh, don't operate between 2 and 4 or 5 days after, or don't do nailing at that time between 2 and 5 days after an injury. But now we know that all these factors may have a contributing factor, but the real reason why the patient has ended up in trouble is because he probably hasn't been adequately resuscitated before surgery. And we're going to touch on that as we go on. So you can have different clinical scenarios. A patient could come in extremis and not respond to your resuscitation and die within 8 to 10 hours. He could respond initially, and by the 4th or 5th or 6th day develop respiratory distress syndrome, and then die by the 8th or 9th or 10th day. Or he could come very late and have septicemia leading up to multi-system organ failure and die after 3 weeks. However, even though the complications or death have happened over different time intervals, the seeds were sown on the first day itself. And Abraham Cowley many years ago talked about the golden hour and said that there's a golden hour between life and death. If you're critically injured, you have less than 60 minutes to survive. You might not die right then. It may be 3 days or 2 weeks later, but something has happened in your body in that 1 hour that is irreparable. Okay, and that culprit is really shock. And shock really affects every system in the body, from the cardiovascular system to the gut to the nervous system to the peripheral vascular system. Every system in the body gets affected as a result of the complications of shock. So so any major trauma sets about a chain reaction of activation of cytokines, etc. Now, the really early deaths within the first couple of hours is usually due to a major brain injury or really massive hemorrhage. The later deaths result from secondary brain injury or post-response failures. And this is where all the pathophysiology needs to be understood. Now, We all know the golden clinical signs of shock, that is hypotension, tachycardia, and oliguria. Okay, so when these three are present, we can all diagnose shock. However, in a young patient, especially in a young fit patient, uh, after the golden hour, the BP is not really, the systolic blood pressure is not always a reliable guide for adequate resuscitation. Similarly, a pulse of 80 could be tachycardia for a young fit patient whose normal heart rate is only 60. So I think you need to really look beyond the normal clinical parameters to be able to diagnose whether the patient is getting adequately perfused. So inadequate resuscitation may be obvious clinically in the classical signs that we talked about, or it could be occult, which we call the occult hypoperfusion syndrome. Okay, and once this happens, this hypoperfusion causes a reduced oxygen delivery, which then increases the oxygen debt, which then leads to anaerobic glycolysis, which then leads to increased lactates and acidosis, which further causes cell death, and you end up in a vicious cycle, which then eventually may lead to multi-system organ failure. So this is the silent sliding pathway that you need to try and avoid. And if in this situation where the patient is primed for complications, you do surgery, then the chances of having major complications increases significantly. Now, how do you decide that the patient has come out of this systemic inflammatory response syndrome? And there are biochemical markers such as the ILA6 or the HLA-DR class 2 molecules, which can fairly accurately predict the clinical course after trauma. But however, these are not practical in an acute situation. It's not available everywhere. Many of the injury scoring systems do not really tell you about the response to resuscitation that the patient has, and there's no score that assists in decision making in the acute resuscitation phase. So I think serum lactate is a surrogate marker which has been shown to be a reasonable indirect measure of tissue perfusion or occult hypoperfusion. So this traffic light system was proposed by O'Toole in 2009, where if the lactate was more than 2.5 millimoles, it was considered a time to stop definitive surgery or not do definitive surgery and go on to damage control orthopedics. If the lactate was between 2.5 and 2, it would depend on the trend of the lactate. And if it was below below 2, you could consider it to be suitable for early femoral nailing. So this is one aspect that you need to look at. Obviously, you need to look at the blood gases and the acidosis, etc. So once the patient, after the initial resuscitation, has a normal blood pressure, normal heart rate, and urine output, you can say he's stable, but you can't say he's completely resuscitated. You can only say that when his arterial pH comes to normal, that means he's not also acidotic, and his arterial blood lactates come to normal. If, however, his blood lactates are increased or he's still acidotic, he is in this condition known as occult hypoperfusion. So you can only say the patient is completely resuscitated if the oxygen debt has been repaid, the tissue acidosis is eliminated, and aerobic metabolism is restored. Now, there have been a number of studies which actually show that the incidence of this occult hypoperfusion or sort of inadequate resuscitation is actually much more common than the classical signs of shock in these polytrauma patients. So if you look at lactic acidosis, lactate levels and the acidotic levels, you'll find a lot more patients who seem to have this condition of occult hypoperfusion. And you can also correlate the return of the lactate levels with the mortality. So if the lactate levels come back to normal within 24 hours, the mortality rates are low. If it takes more than 24 hours but less than 48 hours, the mortality rate goes up to almost 25%. And if it actually stays up more than 48 hours, then the mortality rates are as high as 86%. So how do you deal with this? And this pilot study by Blow and Magliori looked not just at the golden hour, but the silver day. So they looked at aggressively correcting the occult hypoperfusion within the 24 hours and to see if this improved the outcomes for major trauma patients. So I think in the initial pilot studies, they had 31 patients who had raised lactic acid levels beyond 24 hours. And in this group of 31 patients, they had 4 deaths, 6 multi-system organ failures, and 13 significant respiratory complications. And all these patients were otherwise hemodynamically stable. So they then followed it up with a prospective study with 58 patients who had elevated lactates but did vigorous resuscitation in them. And in 44, they were able to bring the lactates back to normal in 24 hours. In that group, there are no deaths, much fewer multi-system organ failures and respiratory complications. While the 14 patients who had persistent acidosis or increased lactates, they had a much higher rate of all these complications. So I think it's the silver day, which again is more important, especially for us dealing with these patients in the hospitals. Okay, now what about solitary femoral fractures? I showed you that case in the first place. And then this study shows that the results are directly correlated to the presence or absence of occult hypoperfusion and not only on the timing of long bone fixation. So this study by Raul et al., they looked at a number of isolated femoral fractures, out of which 27 were completely resuscitated in terms of their lactates and acidosis before surgery, while 20 had occult hypoperfusion. In that, their lactates level was still high at the time of surgery. And we looked at the complication rates of these. You can see there are much higher complication rates and hospital costs in the patients who had persistently high lactate levels. And this is important, and you have to understand that a stable patient is different from a totally resuscitated patient, and this difference can be the difference between life and death. So there are a number of good articles on this. I'll just go through some of the papers that have looked at the pathophysiology of polytrauma. This is from Trentz, who's from Zurich. It's another study which with Moore and Moore from Denver, who have done a lot of work. Moore was a general trauma surgeon, and they did a lot of work on this pathophysiology of trauma. And Bud Palak is an orthopedic trauma surgeon from Australia, but the study was basically from a combined study between Australia and Denver, Colorado. And again, they looked at the post-injury multi-organ failure. And this study from Pittsburgh with Christoph Pape, who's also done a lot of work on this, on damage control surgery, looks at the current theories of pathophysiology of multi-organ failure. So I think these are articles which most of you should go through to understand the pathophysiology of polytrauma. Now, what is the practical implications of this sort of the knowledge that we have understood from this? One is you have to understand the difference between patient stabilization and fracture stabilization. Okay, so this is the practical implications, and this is where you might decide between early total care versus damage control surgery. So acute definitive stabilization of all long bone fractures with patient in the upright position. So allowing the patient to get up early. The hypothesis is that stabilization of the soft tissue releases the inflammatory load. Now, this is true, but remember that surgery in itself is a second hit and causes increased blood loss, may cause hypotension, increases the fluid requirement, and also may cause hypothermia. So this surgery could be a second hit, which you want to avoid major surgery. So this two-hit model was proposed by Moore and Moore from Denver. And they said that after surgery, the patient's inflammatory system is primed and is vulnerable to a second insult. And a secondary insult results in an amplified systemic inflammatory response syndrome, which may then culminate in multi-system organ failure. So this was the model they proposed. The first insult causes a moderate systemic inflammatory response syndrome and also causes a moderate immune suppression. So this is the so-called CARS, or the compensatory anti-inflammatory response syndrome. Okay. Now, if at this time where the patient is still recovering from this, you have a second hit, which could be various reasons. It could be infection, it could be definitive surgery, it could be more blood loss, it could be compartment syndrome. This is called a more amplified response both in the systemic inflammatory response syndrome and in the immunosuppression. And this will then further predispose the patient to infection, to multi-organ failure, and eventually leading to death. So I think this is important to understand when you're dealing with major trauma patient, and you have to try and postpone major definitive surgery to the stage where you have got over this systemic inflammatory response syndrome. Now, there's some clinical parameters to guide you in diagnosing inflammatory response syndrome, and these are include the heart rate, the breathing rate, the blood gases, the temperature, as well as the leukocyte count. So all these things need to be looked at, and if you have two of these criteria, you can say that the patient is in the systemic inflammatory response syndrome. So this is another diagram from the article by Trentz, which looks at the systemic inflammatory response syndrome and the compensatory anti-inflammatory response syndrome, and how they lead to this cascade of various cytokines, etc., which leads to hypermetabolism and all the problems that you have, and also the compensatory response syndrome, which leads to immunosuppression and therefore leads to susceptibility to infection. So I think one has to understand this entire homeostatic mechanism that is taking place in the body to understand how to deal with polytrauma. Now, going back to the history of trauma care, I think prior to the 80s, nobody operated on these seriously injured patients. They waited for things to get better, saying that the patient was too sick to operate, the anesthetist won't take them up. And so, yes, the patients who survived did okay, but overall, the outcomes were very poor. Then in the 80s, a number of authors, including Riska, Bourne, Goris, etc., started doing early total care for the patient. That means every fracture that needed fixation, they would stabilize initially, they would get the patient up early, and they were able to reduce ICU times, improve the outcomes after early operative stabilization. However, as we went on to the later stage, you started seeing patients who were more severely injured, especially with severe pulmonary injury, having more complications with early total care. And this was brought out in this article by Pape et al. In 1993. And then, so they started looking at differentiating patients who could be taken up for early total care, or where you felt that damage control was a better option. So patients who were stable, who were okay, you probably could go ahead and fix all the fractures. But where the patient was still compromised, especially on the pulmonary side, it was probably a major surgery which could then lead to further complications. And there the concept of the external fixator and damage control orthopedics came about. So the surgical strategy was, if the patient was stable and resuscitated, surgery was safe. He was stable but still acidotic, you needed to resuscitate him further. While if he failed to stabilize, then you had to resort to damage control surgery, which was external fixators, etc., before doing your definitive fixation. You also needed to look at other things. One was overzealous fluid resuscitation. That means earlier on, when the patient was in shock, you'd sort of really pour in crystalloids to get rid of the hypotension. But there's a limit to how much of crystalloids you should give. And beyond 750 mils, you can lead to further activation of cytokines. So you have to carefully balance your resuscitation and the fluids that you give. Similarly, hypothermia is a thing that is often sort of neglected in these patients. They're often stripped of all their clothes and they're in an air-conditioned environment. And this hypothermia causes further shivering, causes reduced oxygen delivery to tissues, and increases the oxygen requirement. So this shifts the oxygen dissociation curve to the left and causes further problems. So increased oxygen debt leads to further injury. You also need to be aware of the lethal triad. So all these problems also lead to coagulopathy, hypothermia, and acidosis. And this lethal triad, once the patient gets into it, it's really difficult to get the patient out. What are the other problems that you need to look at the silver day? I think it's debridement. So if your debridement is inadequate and there's dead tissue around, that's going to further increase the risk of sepsis. compartment syndrome and crush syndromes cannot be waited upon. They need to be dealt with immediately. So you have a patient like this with multiple injuries. He also had abdominal and chest injuries, but he had this really frank compartment syndrome in the tibias on the legs. So I think in spite of the other things, you had to go and decompress. You can see how the muscles are bulging out. Some of the muscles already dying, but we could debride it adequately, do a proper decompression, put on external fixators, and eventually save this patient's life. Pain relief is another area that is totally neglected because, again, severe pain alters the physiological response of the patient. It leads to hypersympathetic activity and, again, can cascade the systemic inflammatory response syndrome. So the idea of damage control orthopedics is not doing nothing. It's not an excuse to stay in bed or a convenience for the surgeon or a regression to old techniques. It's the idea that you first do no harm and then repair. So there's a spectrum of care ranging from early total care to damage control orthopedics, and you really need to you need to assess the patient carefully before deciding on what route to follow. So if you have a patient like this with all these severe injuries, you need to stabilize the pelvis, you need to get the hip reduced, and you need to stabilize the femur. So you put an external fixator on in the pelvis, and this girl who was around 14, it was decided to go ahead and plate the femur to reduce the hip, because once you stabilize the femur, and the anesthetists were happy with that. So that was what was done in the first place. And then when the patient was more stable, you could go ahead and do the complicated fixation of the pelvic and acetabular fractures at a later date when the patient was all stable. So I think in developing nations, it's the golden hour is still very difficult for us to really get onto the patients. It's really the silver way that we need to try and improve our management in. There's also a time window which has been worked out in terms of opportunity to do definitive care in these major trauma patients. So I think within the first 3 or 4 days, you have the risk of second hit or hyperinflammation. And then the next 5 days or so is the time window for opportunity. So do your damage control, wait for things to settle down, then go ahead and do your surgery. And then again, you have a stage at 2 weeks or 3 weeks, which you get immunosuppression, and there it may be risky to operate on again. So how do you understand the endpoints of resuscitation? So the patient should have stable hemodynamics without vasoactive or inotropic support. The lactate should be below 2.5 or normal levels. The coagulation profile should be normal in terms of the INR, the platelet counts, the APTT, etc. The temperature should be normal. They should not be hypothermic or have high-grade fever. And the urine output should be adequate, more than 1 is. If you see these patients, they usually go to an oliguric phase, and then they go into a diuretic phase if they have had a severe shock as well. So that's another thing you need to look at. Now, more recently, Valier and her colleagues came up with this idea of early appropriate care. So they decided that maybe waiting for the lactate to come down to 2.5 and the pH to come up to 7.35 may be a bit too long to wait, and you wasted precious time in managing this patient. So they relied on early aggressive resuscitation. They looked at the trend of the lactate. So once the lactate was below 4 and was coming down, or the pH was not higher than 7, not lower than 7.25, or the base excess was more than 5.5 millimoles, they felt it was adequate resuscitation to go ahead and do this surgery. Well, if there was persistent acidosis, they felt you should do damage control. So it is really similar to damage control, but changing the goalposts a little bit. But you really need to have a very well-tuned, aggressive, intensive care management system to be able to do patients in this condition. So I think they showed that you reduced ICU time and had improved outcomes if you did this. But I think this really needs to be practiced in more centers before one can give a definite answer to this. I think the take-home message is long bone fractures, pelvic ring injuries, and unstable spine fractures represent the clinical orthopedic injuries in polytrauma patients. The multiply injured patient is vulnerable to a second hit, which may originate from inadequate timing and modality of fracture fixation. Understanding the underlying physiological response to major trauma is a prerequisite for designing a priority-based treatment plan for orthopedics. So I think at the end, you need to make sure the patient is stable and fully resuscitated, and those are the ones you can manage safely with early total care. While if you have any doubt or they're still acidotic or the lactates are still high, I think a stage damage control concept should be strongly considered for the acute management of these borderline or unstable patients, and certainly for patients in extremis. Thank you very much. I will stop sharing the screen and you can have any questions in that time.
Thank you so much, sir. So, there are two questions in the chat box, and one both have were answered by sir. That one thing what Narayan was asking, can we give ringer lactate for initial resuscitation? It is maybe sir is covering after some time.
Yeah, so that's
And
that's the crystalloid you can certainly use. It's a question of how much to use, and that has to be very carefully weighed in these patients. Okay. And the other things are massive. Now there are massive transfusion protocols where they give a combination of red blood cells, platelets, and FFP together. Okay, so that's the other new thing that has come about in the resuscitation of these patients. So they have a standard group of these things that you give in a particular ratio in these patients who need massive blood transfusion, rather than just keep on giving blood.
And sir, one thing what you have mentioned in your lecture about the lactate, that if it is decreasing trend and below 4, so is it 2.5, below 2.5, sir, or below 4?
For all practical purposes and for most of us, it's still 2.5. Okay. Now, this is a study where in a really well set up trauma unit where they've looked at trying to reduce the waiting time for doing surgery. Okay. Because you have to also look at the flip side of damage control orthopedics. Okay. Because the patient could be on external fixator for 5-6 days sometimes before the lactates come down to 2.5. And with a really organized team, once you know that your resuscitation is going in the right direction, you've controlled bleeding. That's again a very important part of damage control. Okay, so if the patient continues to bleed, the answer is not to keep giving him blood. You need to stop the bleeding, and some of that is going to be covered by Professor Kong, I'm sure, in his next lecture. So you need to stop the bleeding, then only start thinking of giving blood in greater quantities. Okay, so if you keep giving blood and you increase the blood pressure, there's this concept of pop the clot. Okay, so once the BP falls below a certain level, the bleeding tends to slow down or stop. And if you increase the blood pressure by giving a lot of fluids, you'll pop the clot and cause even further bleeding. So there are a number of things that you need to look at when you're resuscitating these patients. And I mean, it's not really completely an orthopedic surgeon's job. I think you need to have a proper team to do this. So the intensivist is the one who will be monitoring these things more carefully. But in terms of stabilization and stopping the bleeding, it is your responsibility.
One more.
The ratio that you're talking about is between crystalloids, plasma, and blood, because they each carry components that are
components. Yeah.
One carries the oxygenation, one prevents the DIC, the intravascular disseminated clotting, and the third one is for volume filling.
Volume, yeah. So I think you have to match these, and they have different ratios and different setups. But basically, the idea is that you don't overdo one thing and not compensate the other.
All right. You don't want any dilution.
Yeah.
So it's usually like a 1:1:1.
So we can take one more question and then we go to Kok-Sun talk. That Sachin has asked about how to prevent hypothermia, sir.
So the idea is that you cover the patient adequately. There are these foil blankets that they have, okay, and make sure the room is really not that cold, okay. So we tend to have the air conditioning on full because, and then the patient is undressed because you need to look at the patient, and this further increases the risk of hypothermia in a patient who is already bleeding and is in hypotensive, etc. Okay, so I think you need to make sure he's adequately covered. You can use a warmer, and you can make sure that the temperature, surrounding temperature, is not too cold.
And one more thing, that warm fluid.
And you need to actually ideally measure the core temperature. Okay, so this is not oral temperature that we are talking about. We are talking core temperature, which means you have to use a rectal thermometer to get this temperature right.
Yeah, we use something called bear hugger. Is air
bear hugger is the blanket. That's the sort of heating system that they have. There are some other systems as well, but the bear hugger is the standard worldwide sort of high quality one that we have.
And sir, in our emergency in Paris, they use warm saline also, so that sometimes they used to give warm saline in trauma patient.
So the idea is that you don't give frozen. I mean, like say, it's mainly for blood. Saline itself is not an issue. It's blood which comes out of the bank is really cold. So you need to make sure that the blood is reasonably warm before you give it. Okay.
Yes.
The saline is usually in room temperature.
Room temperature anyway. So you don't need to particularly warm that up. Unless the room is minus 30 degrees or something.
So, there are so many questions in the chat box. But I think if
we'll continue with the next talk and take it at the end. Okay.
Yeah. Thank you so much, sir.
Sure.
Our next talk is by Kok-Sun sir, and sir is talking about
the screen.
Yeah.
Yeah, we can see.
Okay, so my talk on the second part of the day 2 is emergency management. So this is very practical advice and also some insights that I've had regarding the use of different types of modalities of treatment. Here you see a patient in a typical emergency room setting, and you can already see the C-clamp is already on the patient during resuscitation. This is not even in the ICU yet. Okay, so the principles of care include the understanding that the pelvis, which we are talking about, I think Dr. Mukhopadhaya was talking about polytrauma in general. I like to just concentrate on the pelvis because that itself is a big enough subject. But an unstable pelvis usually means an unstable patient hemodynamically, and these pelvic fractures can kill. Pelvic injury assessment, as Dr. John said, begins in the ER in the first so-called golden hour, and you only can work on a live patient after resuscitation. If you have a poor assessment of these patients and how you resuscitate them, you have a poor understanding of the trauma that the patient has undergone, and with this you will get an poor outcome, and with a poor outcome you don't have a live patient. Injury is often part of polytrauma. It's teamwork matters, and the teamwork means multidisciplinary teamwork, and you will involve people from head to toe, from the neurosurgeon, cardiothoracic surgeon, general surgeon, usually very common, neurologist, and maybe even the vascular surgeon. So everyone has to talk to each other, and you must have some sort of protocol, and you must know who is in charge. And you manage pelvic stability both under primary and secondary survey in an LPLS protocol. In the primary survey is because of shock under C and under circulation and also control of bleeding. And again, it comes back in when you talk about definitive assessment of the associated injuries. And usually the person who decides on the pelvic stabilization or any procedure and the timing is usually either the emergency room specialist, A&E doctor, chief, or the general surgeon, because there are other organs involved. But he must understand that early pelvic stabilization significantly reduces blood transfusion needs. This is well proven in many studies. And temporary pelvic stability can be done before opening the abdomen, the chest, or any other non-orthopedic procedures because it is quite simple and it can be done within minutes. In the secondary survey under LPLS protocol, the main thing is to identify the injury pattern. So in this case, in the pelvis, there are generally three types of injury pattern: the APC, anterior posterior compression, where the pelvis is opened up and you get what we think of as shock. So you have increased the volume within the pelvis, and there are many bleeders and in the veins and the vessels, and also in fracture surfaces. So think of shock. And you think of the bladder, because the bladder is closely adherent to the symphysis, and therefore you may have urethral and bladder injuries. And when the open book is wide enough, you may actually see sacroiliac injuries. So when you do a CT scan, it's not unusual not to see it on the X-ray, as we mentioned in last week's talk, but the CT scan is always required to identify hidden breaks in the ring. The second type is the vertical shear, usually from a fall from height. The associated injuries of crescent fracture and sacral fractures. So what happens is when you think of vertical shear, think of neurologic injuries. So examine the extremities very well and document them if possible. The third type is a lateral compression injury. I think this is one of the more common injuries nowadays because of side impact. And they can be directly onto the iliac crest or onto the hip joint. So think of the hip joint and associated injuries in the ipsilateral femur or knee. And think of the bladder. So in this internal rotation type of D2 fracture, you see a lock facet in the middle of the, and the bladder is caught, can be caught in there, or the urethra can be damaged. Again, sacral injuries are common in lateral compression injuries. And now particularly, please look for this called mora lavale. And this is one of the biggest I've seen. I keep showing this video. You can see the fluid going from the thigh all the way up the pelvis. And this is a shear injury with a lot of blood in there. And we have to drain it for a long time before we can even reach the pelvic bone. When you talk about hemodynamic stability, you want to know what are the relative value of bleeding control measures. The first is self-tamponade. In other words, the patient's body itself with a minor, small displacement of the pelvis. You may actually have pressure buildup in the intra-pelvic space, in the pelvic space, and then the bleeding may stop on its own, especially when the patient is in some shock. But be careful when you resuscitate the blood pressure. You may restart bleeding within the pelvis. Anti-shock trousers we discussed last week. It is only used in the military, and we don't even have it in the ambulances, and probably nobody knows how to put them on anyway. Then there is embolization to stop arterial bleeding, but then arterial bleeding constitutes about 10 to 15% of all pelvic fracture or pelvic disruptions. Finally, we have pelvic stabilization, and this is where we come in to stabilize the patient before he exsanguinates. In the old days, we used to use a bedsheet or the pillowcase or some sort of bandage, and this patient was brought in an ambulance. It was immediately transferred, and the ambulance people have already put on some sort of very crude kind of pelvic binder. This is the modern pelvic binder. It's radiolucent, and you can send the patient for x-rays. But there are 3 locations where you can put them. The proper one is over the trochanterus. That allows examination of the abdomen. If you put it, and sometimes they do slip up, you will occlude some examination, especially when you have a suprapubic catheter. You may dislodge it or do something to the wound. So always have it around the trochanterus in this level 1 position. What about the pelvic C-clamp? I think there's a lot of controversy. It was used quite early on, and it was a lifesaver for us when we first used it in the 1990s, because there were very few items that you need to have. It comes in a little rack in a grip. green sterile bag, and then we will just take it out, and we can even go to either the ER or even the ICU, and we can do it without anesthesia. And usually these patients are either intubated or sedated or unconscious. You allow full access to the abdomen because these bars can be applied. If you want to do a laparotomy, these bars will go onto the thigh, and then you're going to do anything in the thigh, these bars can swing up to the chest. They are generally safe, but not always. There are some warning, and you can see that in this picture of myself as a senior registrar and my registrar, I'm doing the traction on the C-type pelvic fracture, which is reduced with just 2 pins in the iliac wing. The disadvantages are plenty. One of them is the device you see today. Then there are even more fancy ones that are C-shaped and all that. And they are so hard to put on. The patient may bleed a bit longer when you're trying to assemble these. These were the ones that we used to be very simple and very fast. Generally, they are not available because nobody really pushes the use of this nowadays. And it's also not cheap. Sometimes you have distorted landmarks, especially in vertical shear, where you have the pins at a different level and you keep them orthogonal to the body axis. You may actually end up with a pin in the sciatic notch. There are incisions in the buttock, which are of course prone to infection because the patient may be in ICU for some time and there may be soiling of the wound. It hampers femoral nailing because it's sort of near the entry point of the antegrade nail. So you sometimes have to do a retrograde nail, so you have to think about it. And if you want to do a ilosacral screw insertion, you certainly will have to remove it before you put in the screws because they are also in the same region. You can't keep it longer than 48 hours. I kept one 3 days at maximum, but we always release it for a while and we may actually reposition the pins because they can tend to slip when the patient is undergoing resuscitation. And finally, don't over-compress, especially in a lateral compression fracture. So you are closing the book. So it is not literally used in a closing book or an internal rotation lateral compression fracture because you can see the fragment, the bony fragments impinging onto the bladder in the pelvis. How do you apply them? These are all the items you have, and the only thing we add to it is this blade bar cutter handle. The rest are all in the set. And the patient is cleansed with povidone, even lying on the bed like that. You make the skin markings, and it's very simple to find the spot. Make your stab wound, and you just wear sterile gloves, and then we apply the pin and knock it into the bone in the region, in the area of the sacroiliac joint. And then we just tighten it to open up the bars, connect the piece over the top, and then you're done. And this can be done in about 10 to 15 minutes. Then we have the pelvic external fixator, but for pelvic external fixator, you have to arrange for the patient to be in the OR because you have to have air supply for your power drill to make your drills. There are some external fixators you can do by hand drilling, but I think in the modern day, we use a power drill. So patient usually is done prior to some sort of intervention like a laparotomy. You have the high root where you can apply it over the abdomen, provided it's not going for laparotomy. And this allows us to do ilosacral screws from the back in the supine position. There's a low root where you put pins, you only need 2 pins and into the supraacetabular area, which is the strongest part of the pelvis and usually fairly intact unless you have a bicolumn acetabular fracture. And it's a single bar and gives you good access to the abdomen by the general surgeon. You can bring the bars a bit lower by adjusting some of the pin position, but generally you have good access without having to remove the bar. Now, when you look at an X-ray, sometimes you're not sure are the pins in the bone or are they not in the bone. So the X-ray to do, and especially I would advise the junior doctors if they're doing the X-fix pins, do it under fluoroscopy. And what you actually want is an outlet pelvic view. So you do the outlet view, and you can see the pins were all in parallel within the bone, and you can be sure it will stay there and not loosen over the days in the ICU. What about angiography? This is somewhere in the area of the vascular surgeon. So these are, I will show you the protocol later as to when is the timing for angiography. But angiography is very useful because it does stop arterial bleed, which is bleeds faster than the venous bleed. But the prerequisites are not often fulfilled in different centers. You must have an on-site interventional radiologist because he's the only one who has a license to do this. And you must have a suite quite close to the ER or OR and not a few blocks away. You must have a patient that may be in exsanguination but stable and accompanied by all his resuscitative equipment on a trolley and by a ER doctor. And especially it's useful if you find that the pelvic binder or C-clamp that has already been put in doesn't stop any bleeding, so you're suspecting that this requires something in arterial intervention. They must, of course, know you have no contrast allergy and their renal impairment. Be careful because these are nephrotoxic dye, and sometimes take a long time to get the procedure on, and they can end up with renal impairment together with the presence of hypotension. And these are just some pictures of a bleed seen on the subsection angiogram, and then the bleeding stops after gel foam is injected. So you get very slick interventional radiologists, then the first one of the earlier procedures that you want to think about. The only question is when, and that you've got to work out as a team. So I will tell you some protocols. Finally, what else can you do to stop bleeding? This is the ultimate procedure. It's called retroperitoneal packing. And it's when self-tamponade has failed, you have done the external fixator or the C-clamp, you've done an angiography and you find there's actually no arterial bleed. You're trying hard to resuscitate the patient. Try not to do it after a laparotomy, and don't put the packs, as you can see on the right, into an intra-abdominal position because they will float around and lodge somewhere else. The bleeding is not from the intraperitoneal, it's in retroperitoneal space. If you do a incision to apply the packs, try to keep the peritoneum intact so that your packs will have something to pressurize against. Otherwise, they end up within the abdominal cavity. First, you have to evacuate the hematoma. Don't pack a clot. You have to remove the clot and pack the bleeding points, which are the venous plexus or the fracture surfaces. And you must combine with fixation, because if you have an unstable pelvis and you keep putting in packs, you can go into dozens of packs and the abdomen and the pelvis just widen. So you need something to close the ring while you're applying the pack. And generally, we look at them about 24, 48 hours, and preferably the coagulopathy has been corrected. And you may want to slowly remove the packs to see if there are any bleeding you can see, because you may want to pull out, or you may want to proceed with your definitive fixation. Here's an example of a patient with a C-clamp put in, and you can see the markers of the pack. You can do a midline, infrapubic or suprapubic midline, or you can do a phalansteal, and you can reach to the back. And very important is where the venous plexus are. Usually in the presacral area, over the fracture site on the lateral walls, or in the retropubic space in the cave of Rexius. So finally, damage control algorithm. This is what we developed. We have a very simple algorithm which you can follow in any situation. Firstly, you ask yourself, is the pelvis the source of shock? Because patients may have a shock from blood loss from this patient who had amputation, traumatic amputation. If the answer is not from the pelvis, then the ATLS proceeds under the general surgeon's control. If you have identified the pelvis as a source of shock, then you do the fluid resuscitation. They may be hemodynamically stable. That's all, and you've done your x-rays and you found that there's minimal displacement, the pelvic ring is not floating and it's also stable, then you can continue to ICU care without anything, except maybe at most a pelvic binder, which is easy to apply and to remove. If they are not stable, the ring is not stable, but the patient is stable, then you can put a C-clamp. okay, or pelvic binder, whichever one keeps the ring stable to a certain point. Then they can be sent on to the ICU for further resuscitation, control of their bleeding, diathesis, and other things that need to be addressed as a polytrauma patient. Then the second phase comes in where you may have to consider bringing the patient to the operating room. So again, you want to find out, ask yourself, is the pelvic bleeding controlled? If it is yes, then continue the ICU care and let the general surgeon decide when he wants to do exploratory laparotomy, or vascular surgeons we want to do something, or cardiothoracic we want to do something. If the pelvic bleeding has not been controlled, then after blood resuscitation and you find that they're still unstable, and the binder or the clamp has been put on and the patient does not respond, then you may need to add an X-fix in the OR, and they can be either stable or unstable. If they are both unstable, then and the ring is stable, then your next choice is either angiography in the angiography suite to look for bleeding arterial bleeds, or open pelvic packing if you think that the pattern doesn't seem to support arterial bleed. So it depends on what services that are available at your call, because if you don't have an interventional radiologist in the midnight in your center, you have to do the open pelvic packing to save the patient's life. So the take-home messages are here. This is a multidisciplinary trauma protocol. So you have to develop it in your hospital system. Large or small, you will sure to see a trauma patient and you need to have some sort of protocol. Doesn't mean you have to always be in a trauma center. Rapid assessment in the first hour, as mentioned by Adam Towley. Identify the fracture personality from the x-rays and perhaps CT scan, and try to identify possible sites of bleeding. Correct the hemodynamic stability as mentioned in the first lecture this evening. Then always have some sort of algorithm so that everyone understands what is the next step, and you can modify them or cement them as a guideline for your center. And external stabilization can be fast and effective, and you should do this as often as you can. Everyone is scared of the C-clamp, but I find the C-clamp is so fast. Sometimes my registrar done it before I arrive. And finally, pelvic packing is something that may be fearful because you're going into a blood-filled cavity, but this is another life-saving procedure that you must learn. Thank you very much for your attention.
Thank you, sir.
Okay, great, thanks. Okay, any questions?
Yes, sir. One question from Sumit is, sir, he want to know about approach of pelvic packing.
So I think mentioned it, yeah.
Yeah, it's either below the umbilicus you make a midline, either a midline incision, especially if you're with a general surgeon or with a urologist, or you can do a Pfannenstiel, because if your Pfannenstiel may be one of your approaches to fix fractures later, so you can decide. So either way gets you into the retroperitoneal space. You don't have to worry so much about entering the abdominal cavity because there'll be a lot of blood before you even see the abdominal cavity. So you make your incision through the linea alba in the midline, and then you will see blood just coming out. And what you have to do is use your hands. So you basically try to remove all the blood clots. You may be coming out in buckets, or you can use a sucker, but usually I find the scooping them out is the fastest way to evacuate. And then you're knowing the fracture pattern. It could be the sacral fracture, or it could be the pubic rami symphysis. So the packing goes in by hand, and you just put your hand down one side of the gutter along the pelvic rim, along the pelvic inner wall of the pelvis, and try to reach the midline. You should be able to reach it quite easily. It's not very far away. Then you pack it on the other side, and then you finally lay packs in the front of the retropubic space. And then you...
Essentially, the hematoma in a pelvic fracture is retroperitoneal. So you don't open the abdominal cavity. Okay, so you enter through the retropubic space and then go back on both sides. So you start on one side, do the other. Keep packing till you've completely closed the cavities. Now, it's important, two things to remember. One is whenever the general surgeons are planning to take a patient for a laparotomy and he's also got a pelvic fracture, it's important to communicate, because we've seen this happen sometimes where there has a pelvic fracture, the patient goes in, and the moment they open the abdomen, the patient is going to, BP is going to crash, because suddenly all the effect that has happened in the anesthesia goes away as soon as the muscles are relaxed and they do the laparotomy. So it's important for you then to put your fixator on before they do the laparotomy. Okay, and this communication is really very important.
So one more doubt about the tranexamic acid, sir. That when we should give it in polytrauma patient, in all polytrauma cases we can give it, or in selected ones?
Which one? What are you giving?
Tranexamic acid, that's the to reduce blood loss. Okay, so yeah, I think there's been the two studies which actually looked at it and showed that it did reduce the bleeding from acute trauma and actually was successful in terms of saving lives as well. So I think it needs to be given early, but it's not this thing for stopping the blood loss from the source. Okay, so you give it to prevent oozing, etc., but the main bleeding has to be stopped.
Yes, it's a anti-fibrinolytic, so it doesn't it just prevents breakdown of clots, and you should give about 1 gram in the first hour, and then you infuse over the next few hours, 3 or 4 hours. But you should don't bother if it's more than 3 hours, because it hasn't shown to be effective after that. So
yeah, so it's in the early stages, and remember, it's not going to prevent massive bleeding. It's the okay. So if there's any major bleeding, you need to stop that first.
And so we have one more confusion about that one. Do it increases the risk of DVT also, sir? Because in pelvic fracture, that is another risk. So
yeah, but in the first few hours, you're worried about bleeding. Okay, so that's when you use this.
Yes, sir. And sir, one question from the previous talk is,
and I think the studies have not shown it to significantly increase DVT. Also, I think they've looked at studies for that.
Well, you're having a bleeding tendency rather than clotting.
Yeah, in the initial thing, it's a bleeding tendency that happens. Okay, your platelets drop, your coagulation profile goes haywire, so you need to stop the bleeding. Later on, you have the problem of DVT and hypercoagulopathy, which again you have to take care of.
And so, from the previous talk, what is the incidence of using C-clamp nowadays, sir?
The incidence is going down because the pelvic binder is available anyway. It's very easy to get. It's not expensive. The C-clamp has evolved, and you can't get the old version, the quick version anymore. Now you have a fancy version that is. It takes a PhD guy to work out what goes first and what goes second. I prefer the very fast one, but that was like a
simple one, yeah.
Yeah, it's like a carpenter's clamp, you know. It's so fast. It just
so I think
pushes
so. The basic problem are two in India. The problem is availability. So it's not there in most centers, so you can't use it. And second, because of the binder, a lot of situations where you needed urgent external fixator, the binder does the job. Okay, so it has reduced the incidence of putting both external fixators and the C-clamp.
So, yeah, one thing is that you must understand the external fixators don't close the posterior injuries.
Yeah.
So there's still, with the external fixator, I will leave the binder on as well.
Yeah.
So about the binders, or when we are using the seat, so do we use to open the seat in between, sir, or after some interval? And another thing, for how much time we can put that seat or pelvic binder, sir, and then we can go for X6. The maximum time limit, if there is any.
There's no maximum time limit, but the main problem is ischemia under the skin. So it's like a tourniquet, you know, you have to release it every now and then. But usually we leave it on until the first 3 to 4 hours because we are busy in the patient. But every now and then, when you cover the patient up and don't look at it, you know, trying to keep him warm and all that, some people forget that the binder is still on. So there must be a protocol to examine the binder and release it and see whether any response from the blood pressure.
Yeah, and if you're having to keep the binder on to keep the bleeding down, then that's the situation where you might plan to put a fixator on, as it, because you can't keep the binder on for more than 2 or 3 days at the most. Okay, so beyond that, it becomes a bit of a problem. Okay, so if you find that every time you're losing the binder, it tends to bleed again, or his BP tends to pulse goes up or his BP goes down, then I think those are the ones who probably need to have a fixator or a C-clamp on.
So, Dr. Rajiv, Dr. Rajiv has one question in the chat box. When to do embolization?
Yeah, I just answered.
So if your fixator, even after you put on your fixator or C-clamp, the patient is bleeding from the pelvis, okay? So that means in spite of transfusion, his BP is not stabilizing. That means your fixator is not controlling the bleeding. Okay, so now then you have to decide between embolization and packing. Okay, and depending on centers, so if you look at Europe, it's all packing mostly. Yeah? Now, some specialized centers where they have these vascular intervention, vascular guys available throughout, they will go for embolization. It usually means taking the patient off from the emergency area into the angiographic suite. So that has its own problems. They need to look at the setup and then decide which is the more suitable option to go for. Yeah, I think there are centers which prefer angiography as the embolization as the first thing, and I think most centers probably go for packing rather than embolization, because majority of this bleeding is venous. The severe bleeding is mostly venous rather than arterial, although you have some people who, there are a few people who strongly advocate embolization rather than packing. So I think there's still a controversy there. And there are some people who do both.
Now, in our ORs, we have one we call hybrid theater. So in the hybrid theater, the vascular surgeon and the orthopedic surgeon have a sort of biplanar C-arm. So they can do either one, and it's a matter of who wants to get a bite at it first.
I think in a couple, 1 or 2 centers in Hong Kong, they do both. So they embolize and pack as a routine for the massive bleeders. That's the other.
So
the problem is if possible, and there's an arterial bleeder, I'd rather have the embolization, because
obviously
the packing. Firstly, you have to do it yourself, and secondly, you have to go in a few times, and then when you want to do definitive fixation, there's a higher risk
infected and things like that.
You can have a higher risk of operative infections.
Yeah, true.
So another question regarding the fluid only is when to decide between colloid versus whole blood in emergency.
Colloid versus
whole blood means when patient comes, which one is better?
So colloid is something which now is hardly used at all. Yeah. Okay. So I think
he means plasma.
Yeah.
No, I think colloid is meaning of things like Hemaxil,
gelafundin or something.
Yeah, things like that. Those are hardly used at all today.
We don't use it.
So you use a combination of, and you don't get whole blood in any blood banks anymore. Okay. So you only get products. So you get blood cells, fat cells, or you get FFP, or you get platelets. Okay. Plasma or platelets. So you have to use one of these. So
sometimes, Arvind sir.
Just extension of this question. So about the management of resuscitation part. this blood and FFP and the platelets. Lot of patients with shock having tendency for coagulopathy also in pelvic injury. So is there any combination of this? How much of this blood and FFP should be transfused along with platelets? Is there any rule wise?
Yeah, so there are various protocols. Okay, so they'll use 4 or 6 units of fat cells with plasma and FFP in a certain ratio. Okay, it's usually close to equal ratio of the three.
Yeah, even
So I think when they're massively bleeding at that time, you don't worry about DVT. Okay, so when the stages that you worry about DVT, here you're worried about stopping the bleeding. Okay, because if you don't stop the bleeding, that patient is going to die anyway. Okay, and colloids, of course, also. I mean, crystalloids are also added on, of course, but again, not massive amounts of crystalloids. So they have different ratios. Some centers have slightly different ratio, and others have a slightly different ratio of the three things. And then you also add cryoprecipitate. There are some other things which they add to it, depend calcium, etc. All get added on, depending on the number of transfusions you have to give.
so you have mentioned in your talk about the window period, sir. So how we come to know that patient is in window period? About the lactate you have mentioned. Any other thing we can?
Yeah, so everything that we talk, they should be their blood pressure should be maintained without inotropes. The urine output should be adequate. That is at least 1 mil per minute. That means 60 mils an hour. The catabolic state should be improved. The coagulopathy should have been okay. Okay, so the platelet counts and the INR, etc., should be normal. Okay, so
And
those
their
are the
body temperature as well.
body temperature and hypothermia. So they should not be hypothermic or febrile, either of them. Okay, so all these things are signs that the patient is very. And usually this is if in a major injury patient. So a lot of the really severe injured patients probably don't survive in a lot of parts of India, unfortunately, because they either don't get to the hospital in time, or the hospital they get to is not equipped to deal with these major trauma. So, because it's not one person who can deal with this, it needs a full team to deal with these patients. Okay, so until you have a setup where the ambulance immediately picks up the patient and takes them to the correct center, till we organize ourselves in that way, we are losing a lot of these patients before they even get to us, and others who, because they're already in a state where you can't do much about them. So I think all these things have to be taken into account.
So one common confusion in the emergency setting, what we used to have, sir, in which patient we should put the urinary catheter, because in shock there is maybe because of shock that urine is not coming, or maybe because of some damage in the. So how
So
to?
I think so. If there is no pelvic or injury, then it's unlikely that he's got a problem with the urethra or the bladder. Okay. So of course, if there's a pelvic fracture, you would look for blood in the meatus. As long as there's no bleeding per urethra or blood in the meatus, you're probably okay to pass a catheter, but then pass it gently. Don't kind of bang it through or barge it through. Go carefully. Make sure you get urine before you dilate the balloon. Okay, that's another thing that you have to be careful of. Okay, because these patients, sometimes you could have the catheter stuck somewhere and you think it's no urine because of shock, and you dilate the balloon and then you rupture the urethra. Okay, so that's another thing you have to be very careful of. Okay? And if you're worried, get help from the general surgeon. So if there's got bleeding the urethra and he's got a distended bladder, then he may need a suprapubic. Okay, so with ultrasound, etc., you can tell if the bladder is distended. You can put a suprapubic in.
So mainly we have discussed most of the thing about the unstable pelvis, but sometimes if patient comes with a stable pelvis, like there is just tenderness, And after the X-ray, when we suspect that it may be because of neck or femur fracture or something, it comes in the elderly patient that it is just the pubic rami fracture. So in those cases, sir, it is just to non-operative treatment, or do we still have to do CT scan for those patients also?
Sorry, you're saying that in a minimally displaced pelvic fracture, do you need to do CT scan?
In an elderly patient, I think.
Oh, elderly patient. Yeah, I think the CT scan is a planning for surgery. The one you don't actually need to rule out is the pubic rami fracture because you can see it, but always be cognizant that they may have sacral fractures, which you can't see because they're osteoporotic. So there may be some enlarged abdomen, soft tissue shadow. So if the patient has any pain or tenderness in the pelvic ring, locate the pain. If it's posterior, suspect posterior lesion. Then in my place, of course, everybody gets a CT scan. So the question doesn't come in. We have the CT scan sometime before we examine the patient.
Yeah, I think what the issue here is that if you have a pubic ramus fracture, which is even minimally displaced, there's a high chance there's also a posterior injury. In fact, a lot of studies say that it's almost always that there's also a posterior injury. Okay, so you need to know that. The second thing is today, especially in the West, the elderly patients with these fractures are being treated a bit like we treat hip fractures. Okay, the idea is to get them mobile. So unless it's a completely stable injury where you can mobilize the patient, you will want to fix these, and now there are various percutaneous methods to fix these fractures so that you can mobilize the patient. Because again, with an elderly patient, you don't want him lying in bed for 3 weeks or 6 weeks. So even if there are fractures which look and which we treat conservatively, there they would want to operate on them and get them up and about. And I'm not sure Singapore must be also going towards that.
Not always.
So much, yeah.
We still have subsidized healthcare.
Okay.
It's not so expensive to stay in the hospital for a few. But I agree. If the patient, you want to get them up and about, generally you have to put some ilosacral screws or whatever percutaneous technique to stabilize. Even minimally displaced fractures, patient is more comfortable, requires less analgesics and opiates and things like that. So there are some general advantages of recovery, usually faster than, and avoid the prolonged recumbency of 4 to 6 weeks in bed.
A lot of these fractures which we were treating conservatively earlier are now getting fixed. Today with percutaneous fixations, you can do them with minimal blood loss, etc. So iliosacral screws, iliopubic screws, even posterior column screws through the ischium, which some people are using with minimally invasive techniques. So they're enough to get the patient mobilized.
And
this is not part of today's actual discussion. This is something we'll be discussing maybe in the next talk when we talk about injury fixate. There's a talk on minimally invasive surgical techniques, so that we discuss that.
Just one question from my side, sir, about the pelvic binder. That I think there is no contraindication of pelvic binder. We can put it in all the suspected cases of pelvic trauma, sir. Is it so?
So you have to be careful where there's a severe Morel-Lavelle lesion. Okay. So if you have obvious gloving injuries, that's not an area where you want to put a binder. Okay. Of course, you can put it on for some time before you can get a fixator on, but you want to get a fixator on quickly and deal with the Morel-Lavelle lesions quickly. Okay, because if you put a binder with Morel-Lavelle lesions, that skin is going to get necrotic in no time.
Well, as I showed with the C-clamp, binder works the same way by closing the book. So in the majority of cases, they are open book APC type of injuries. Lateral compression should not over compress. So lateral compression.
They don't often need binders unless they're also vertically unstable.
Exactly, yeah. Some vertically may help with trying to, but you have to pull traction on the limb first. And then they will displace quite quickly because the skin is the point where they slip out. And there are some people who have very big soft tissues, large soft tissue bulk. The binder is not that effective unless it holds bone. So even in the, you get the trochanter, sometimes there's so much skin between there's so much soft tissue that the binder slides up and down, then it becomes ineffective.
So I think there is, we have covered most of the things for today's talk.
Okay, so thank you very much. Thanks, Kok-Sun.
Thank you, John.
Thank you, sir.
Great. So next week, I think we're talking about the definitive fixation and TV and push.
Yeah.
Great.
Okay.
Thank you.
Thank you, everyone.
Yeah, bye.